And good evening, everybody, and welcome to Maternity and Midwifery Hour. We're back. We're back. It's series 17, session 1, just in case you didn't recall. And welcome indeed to this session this evening. And my name's Sue MacDonald, and I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my delight to be chairing this session this evening. And I'm joined by two super midwives, Anna Madeley and Stephanie Michaelides. There they are with me. Here they are. And as we always do, or I always do, is I just invite my guests to share a moment of their week. And it doesn't have to be a big moment. Sometimes it's a big moment, sometimes a tiny moment. So shall I start with Anna? Anna, your moment of the week, please. And welcome.
Thank you. And it's lovely to be here. Thank you very much. So my moment of the week hasn't happened yet, but I'm looking forward to
Oh,
it. Is that okay to say?
cheating, but we'll
It's
let you.
slightly cheating, but it's only Tuesday. So I am very much looking forward to my moment of the week, which will be Saturday. So Saturday, I have the delight of meeting some midwives. We're coming from all around the world. We've known each other while we were doing our doing and are still doing PhDs, and we are all meeting to have lunch on Saturday. And one of my colleagues is coming from Australia, so I'm incredibly excited. So.
Well, that I think that's a big moment. And I can just imagine, like, whenever midwives meet old friends, you just start picking up where you left off, and it's just so exciting and lovely. So enjoy, Anna. That's lovely.
Thank
Thank
you.
you so much for sharing that. Now, Stephanie, you'll have to compete with Anna now.
Oh, couldn't possibly compete with that whatsoever. Just to say, my moment of the week so far has been the fact that I've had other students, and one of the things as a teacher that we try and do, we try and share information with our students, but it's really wonderful when those students take forward the fact that they have enjoyed learning and they're going forward as teachers themselves. That really does give you a heartwarming feeling to know that other people are going to take forward and increase the knowledge that you have given them to go forward and teach so the continuum continues. So I had one of my ex-students who rang me and asked her to make sure that I could give her some hints on how to move forward because she's been invited to give lectures on the systematic examination of newborns. So that was really a wonderful moment to know that more and more of those students are going forward to become teachers and many other roles. But it's good to know that what you're doing is useful.
Fantastic. No, that's a lovely moment too, because that's about our next generation of teachers. And
Mm,
as three of us as teachers, that warms your heart to think that the next generation of students are going to get good
mm.
teaching, high quality teaching. And it's kind of like a feedback that you've kind of got it right. So well done, and well done both of you. And thank you for sharing that moment of the week. Now I'm just going to go back to my welcome and just remind our new people and our old people, because I know that we've got a lot of old friends with us this evening. So welcome indeed to you. It's lovely to see you again. I don't see you, but you see me. And then we've got some new people who've signed up. And you may not know the story of the Maternity and Midwifery Hour because we've been here. This is our 5th year. I can't believe it. And we were born in the COVID-19 lockdown, the first lockdown in the UK in the March. Our first one was the end of March. And it was all about making sure that midwives, student midwives, anyone actually in the maternity services could have some sort of link, some sort of area where they could discuss, especially COVID at that time in maternity services, but also other maternity and midwifery things. And that was a really good connection. It's a bit, I suppose it's a bit like the beginning of the refresher courses. Now I'm really showing my age. I wasn't there where they started, but that was why refresher courses came from originally in the 30s. But it's been very successful. And we don't really talk so much about COVID, though we know it's still around. We're looking at all sorts of things within midwifery and maternity. And what I'll say here now is if any of you are watching and you think, well, they've never done such and such. Why haven't they done this thing that I'm doing at the moment? Get in touch because we're very happy to welcome anyone from the maternity services to share what they're doing and their kind of their viewpoint on the world, because it's all really good to share and good to learn together. Now, the good thing is everything we do in the Maternity and Midwifery Forum is recorded. So if you have a power cut tonight, or if you have to rush away, don't panic. You can always catch up a bit later. The other thing is you're going to learn some stuff this evening, and some things are going to challenge you, which is good. We like that. And you might want to watch it all over again, and you'll be able to. And you can also, and we're very happy if you do this, share with your colleagues. Very good if you're in a student group and your other students were very busy doing other things, like working, to actually get together and watch the video and have a discussion about it, because that helps you kind of seal and understand the learning better. So please do that if you'd like to. Now, the other thing is this is very good for revalidation, so you can always get a recording afterwards, and you can subscribe to Matflix, and you'll see on the resources sheet that comes with this hour, you've got the Matflix link up, so you can check out what's there. Health warning to you. You go into the Matflix kind of portfolio, you might find you're there 2 hours later, having been pulled in by something delicious and interesting that you didn't think you were going to listen to, but you end up watching and listening. I think there's something, and it's something about being a midwife. It's really good to hear other people talking. It comes alive for you. So do access that if you can. Now, I do have to do a quick news flash. Right, the 24th International Labour and Birth Research Conference has been taking place at the University of Lancashire. So I suspect there's going to be a lot over the next few weeks coming from that. We weren't able to be there, none of us tonight, but I know some of you who are watching might have been attending. So share with us what went on. It's really good. It's always good to know. Today is World Patient Safety Day, just in case you didn't know, and 21st of September is the UN International Day of Peace, and I hope that there's a degree more of peace, because that's what we need in this world. Okay, the other news, big news in the news on maternity is that 14 NHS Trust maternity units are going to be part of the review by Baroness Amos, with an interim report coming in December and the full report coming in spring, I think March, April time. The other bit of news is that the Embrace report and the National Perinatal Audit Report, NPA, have both been released this very week. Now, I have to share with you, that's the NPA, that's what it looks like. And then the Embrace, they always look about the same. And those of you who have been in midwifery a while will know the importance of the Embrace report. But what's fantastic about this is they do a really good executive summary with fantastic infographics. There, just a summary of it. So it's sad, really. Well, it's very sad that we still have this ethnic differences and deprivation impacting on maternal mortality. We still haven't got there, and we still need to still carry on addressing that. So that's very much in the Embrace. The NPA says more about it's a national maternal and perinatal audit is much more about things like types of birth and data. There's a lot of data in it, and probably Anna would be able to juggle all of this very easily. But it's a very interesting report, and they do go in for more research type infographics, I would say. Takes a little bit more time. I haven't gone through it because I haven't had quite time. So this is my tomorrow's activity for that. But the key things for me that I picked up just glancing through was 1 in 3 births was through induction of labour, which seems awfully high to me. And normal vaginal births after were just under 50%. Also, that seems a bit low to me. And 1 in 7 births after cesarean section were vaginal, and that doesn't seem quite high enough to me. So I think this tells us the things that we need to do and need to work on. And also the other piece of reports that I was interested in was this report on exploring Black women's experience of consent to vaginal examination during labour. And again, these are all on your list, and there are links there to look at the actual meat of it. this was very interesting to me because we're going to be looking at consent, and this is what it looks like. Just to prove I have it. And I think the thing that got me was it showed that most of the women who were interviewed didn't think they had a choice about whether they had a VE or not, vaginal examination or not, and they didn't feel they had enough information. And they also, one of the sentences were they were troubled and shocked by the experience. And it's a very intimate experience for women. And I think sometimes if you're in it, you may not always remember that. I think we do need to remember it. And this is an important piece of work to look at. And I think there are several elements to this work. So that's your bedtime reading. But on to the meat of and I'm trying to talk really quickly to get to our wonderful speakers. And we're going to look at changing knowledge. Well, knowledge is, I think that underlines knowledge is changing all the time. And it's very difficult, I think, sometimes to let go of an old bit of knowledge as a new little bit of knowledge comes along. But we do need to, because as new research, new evidence comes along, we need to look at how we put that in practice. So we're going to be looking at language and approach to seeking consent. And then we're also looking at examination of the newborn infant in the birthing room. I'm not talking about the whole examination, but Stephanie will make that clear anyway. Both really important for us as student midwives and as midwives. So I'm really so delighted. I have two wonderful speakers, and I want to welcome Dr. Anna Madeley, midwife, academic and clinical midwife with experience in all midwifery settings. She's deeply committed to mentoring and teaching the next generation of midwives, and I'm so delighted she's with us this evening. So welcome, Anna. The screen is now yours.
Yes, we're going to be talking about sort of consent and the issues that we come across as clinicians. And certainly we have student midwives that have expressed concerns over some of the things that they're seeing in practice. Much of my background and my research background, if it isn't looking at home birth, it's looking at some of those consent issues and issues around what we tend to term as birth outside of guidance. And I'm going to be challenging you today to start thinking about this slightly differently, because I've only got 15 minutes and I could talk about this for hours. So this is going to be a quick win. And I say a quick win, but I'm not sure it is, because I am going to be asking people to think sort of systematically as part of the systems you work in, but also sitting with your discomfort around some of the issues that come up with this, and how just by changing our language can reframe how we think about the care that we're providing and the care that we're planning. So I framed it around the problematic terminology of birth outside of guidance, because that's where most people are understanding this sort of care that we're providing and care planning. Why am I looking at this now? Well, I've been looking at it for a very long time, and there is more and more scrutiny over women and other birthing people that are making choices that perhaps are making us uncomfortable, that make services uncomfortable, that we might see as extreme or not. They might be small choices, and I'll touch on what some of those have been when I've looked at them in my research. But equally, there's been a number of focuses made on by our regulator, by the NMC, and also by the RCM, to try and provide support for midwives and other clinicians that are care planning for women who are making challenging decisions. So what you'll see on the screen there, you'll be probably familiar with the RCM Care Outside of Guidance. And most recently, if you saw it last week and over the last kind of 2 weeks, the NMC have published their principles for supporting women's choices in maternity care, addressing some of those issues around things like what they've termed unregulated birth workers, but also addressing and consolidating what our rules are, what we can do to support women. But what I found really interesting is the language and terminology still used in this space. And the wonderful Tracy McCormack, if you watch the videos that the NMC have provided, says at one point towards the end, I don't know why we call it this, it's just personalised care planning. And that's part of what I want you to think about when you go back into practice, amongst some other things as well. You will also notice as well that we're focusing quite a lot now on the outcomes for women making challenging decisions, and the data that certainly the NMC have provided, and you'll see their MNSI, is predominantly around those poorer outcomes. But we're looking at those big choices. We tend to focus on those choices, such as your VBAC2 at home that's decided to have twins, for example. But it's more nuanced than that. And all of the issues around consent and how we obtain consent and how we frame what their care looks like can be applied whether or not it's someone making a seriously challenging decision, or whether they've just said, no, thank you, I don't want a vaginal examination, which ties really nicely with what Sue was talking about. So we just want to touch on and acknowledge some of the anxieties around this issue. Because when I speak to midwives around the country, when I speak to systems around the country who find this particularly challenging, what they tend to say is, but I don't feel protected. I don't feel that I can support women to make choices that looks outside of guidelines, whether it's declining care, because I'm frightened that I'm going to end up in front of the NMC, or that there's going to be a poor outcome and I'm going to be taken to court. So there's still quite a lot of work to be done around supporting midwives. But of course, we are protected. We're protected as midwives to support women to make choices. We are supported in law. There is case law that supports us to do that. We are supported within our code, whether or not it's the NMC code or whether it's the GMC. It has a huge amount of guidance around supporting women and other birthing people to make choices. But also we're now starting to collect data around what those choices are looking like. But it is still creating a lot of anxiety in midwifery circles and elsewhere. It's also creating anxiety in women, because women are making these choices more and more. We haven't had the evidence base. And again, if you go back and engage with some of that work that the NMC have done, they have collected data now around things like free birthing. And whilst I include free birthing in my work and discussions, it's not the only thing. That's one of those sort of end of the line um, uh, planned births. When I look at it, I'm looking at it through the whole continuum. I'm looking at, a woman doesn't want to scan. We're recommending that somebody books by 8 weeks, but actually they've decided they don't. And all of it applies, whether women are free birthing, whether women are making those more discrete decisions. What we don't have is the data, but the NMC has got some data, and I was rather excited when they presented that, I have to say. So kudos to the NMC for that. More work to be done around the country. But what are women telling us? What have women told us about, or what women told me about how they are treated when they make those choices, and how particularly language and the language that we use around these choices affects them? Well, I have a whole 100,000 word thesis that I could share with you that I had to distill into 4 key areas. So these are the ones that I'm going to share with you this evening. Firstly, particularly around the language that we use, women and other birthing people told me that they don't like the shame and stigma around categorization and labeling. So there are some quick wins in terms of the language that we use. And again, if we go back to the RCM and the work they did in their rebirth project, which is fantastic, it talks about how we can really challenge those labels around shame and stigma using someone's name rather than them being the VBAC in room 4 or the raised BMI in room 6. Makes a huge difference. Being categorized and labeled is stigmatizing and in and of itself. If you delve into the sociological literature, which I won't do tonight because I haven't got the time, you will see that stigma is there's a line to be drawn with how people are labeled, the dehumanization of them and their condition. But also clinics and pathway names. More and more what we're seeing now is that we're seeing it framed as outside of guideline. And I'll park that there because I'm going to come back to it, because that's one of our quick wins. But equally, how we name our clinics, the pathways that we put women on. And what I do see a lot now is outside of guidelines, which seem a bit odd to me. But again, these are quick wins that we can put in place for our systems, for our individual language and our practice, that can challenge some of those issues. Again, going into this institutional risk depersonalisation and enforced timetables, one of the things that women told me around particularly language and the way that they were labelled is that they were labelled and put into a basket according to their perceived risk. whatever that looked like. And they didn't like that. It was a stigma around their body not working. The fact that, of course, we've given up on them already because we've already labelled them with, that high risk, complex woman, which of course women can be. They are complex, but they're still people. And then there's this thing around unique normativity. What might be abnormal for us and might be risky for us is normal for these women and other birthing people that are making these decisions. And again, anyone that's heard me talk about my research will know that I talk a lot about this expectation of compliance. So if we come into our care expecting women to comply with what we have recommended for them, whatever that looks like, whether it's evidence-based, whether it's not, and they then don't do that, we then label them. The language that we use, the difficult woman, the difficult person, the non-compliant woman, will immediately start to be a challenge to them, and they will withdraw from care. So there's a couple of big wins. This is what I'm going to ask you to do, is I'm going to ask you to start thinking about two particular terms. So the first one will not come as any shock. It's this outside of guidance. And I know that the new guidance from the NMC calls it outside of guidance or outside of guideline. And I see many trusts talking about outside of guideline, but this is problematic. And the reason it's problematic is because what we are doing then is we're positioning guidelines as the authority. When you look at what informed consent looks like, when you look at what informed decision making looks like, and there's some fantastic models that, again, the RCM have used and NHS England, it shows that it's a culmination, this informed decision making and consent is a culmination of the needs and wants and preferences of this woman. What is their history? What can we do? What are the recommendations? And then they making the decisions in the middle. So if we are positioning guidelines as authoritative, which we are by saying they are outside of guideline, we are then stigmatizing women, and we are making them feel that their choices, if they are not what we expect them to do, are then wrong. And that can be problematic in and of itself. So when you are naming clinics and pathways, try not to use outside of guidance. What I would like to see, and in the next sort of few years, that this term goes, that we start talking about personalised care clinics, personalised care pathways, because that's what it is. I'm with Tracy McCormack on this. That is what it is. Choice equals personalised care. And that informed decision making is about that ongoing organic decision. So that's outside of guidance as a problematic term and what we need to do about it. The next one that I'd like you to have a think about is this one. And I remember as a student midwife, which wasn't a million years ago, writing in people's notes, refused care. We then went away from that because, again, wasn't seen to be a term that we should be using. And this is what we see now: declining care, declining a VE, declining a scan, has declined to see the midwife. But what this does again is it positions the recommendation as authoritative. They are just recommendations. When you look at what a guideline is, or even if it's a NICE guideline, trust guideline, it's a set of recommendations which should be evidence-based. On the whole, we say they are, but they should be evidence-based. And if we are offering something, then there's a choice. And one of the choice has to be no. And one of the analogies that I used that I borrowed from the police was around a cup of tea. If you offer someone a cup of tea and they say no, you're not going to force them to drink it, because that would not be right. That's a consent issue. So women aren't really declining care. What they're doing is they're withholding consent. And if we reframe how we think about withholding consent and declining care, what that does is it changes our mindset when women say no. We worry about declining care for a number of reasons. Sometimes it's a metric, sometimes we have to measure it. If they decline newborn blood spot screening, for example, might decline vitamin K for a well baby. They might decline all sorts of things. And then those coercive practices start to happen. And women have told me this. I've got many examples of making discrete, small choices where they're declining care. And actually what they're doing is actually saying no, thank you, and it's withholding consent. So my second plea is start to think of it in that way and start to change your terminology so that it is withholding consent rather than declining care. And this is supported in the code. For midwives, the code is very, very clear that we should be supporting women in whatever those choices are, including the right to refuse, decline, and say no, thank you to care. And that is enshrined in law as well. So this is my plea to you this evening, is to reframe our language. It's a very small win, but it's something that can make a fundamental difference to women in our care, to their offspring, to their families. And this is what is going to make women come back to us and feel that they can trust us, because it's all wrapped up in consent. And that is all I'm going to say on the matter. Thank you very much.
Wow.
Is that okay?
Yes, that is. That's left. I think that's left our colleagues, our participants, with something to think about. Now, if you have any questions, or if you think, oh, that doesn't quite make sense, or how does that work in practice? Start writing in the question in the wee chat box, and then it'll come through to Anna at 1:45. So thank you so much, Anna. That's
Very welcome.
I like the idea of this sort of reframing. It's really useful. Thank you. And we'll now move to Stephanie, who's, I'm also delighted to welcome Stephanie Michaelides, considered to be one of the leaders of neonatal care and examination newborn within the UK, another dedicated midwife and teacher. And one of the things about Stephanie is she doesn't just teach in the classroom, she's out there in the clinical area. I'm very passionate about that. So welcome, Stephanie. The screen is now yours.
Thank you for that introduction, Sue. Just to say what Sue said at the beginning, what I'll be talking to today within the next 15 minutes, and again, like Anna, it's a big ask, but I'm going to do my best to give you some of the main points for us to, start to debate the issue. I'm talking about the examination following birth. I'm not talking about the examination that's taken within 72 hours, which is the NIPE included. I'm talking for that first hour following birth. And we need to make sure that we put it into the context of why we're doing it. We're doing it to identify any problems that the baby may have for adapting to postnatal life, to identify whether that baby requires any support to adapt to this postnatal life, because there's huge changes from in utero to postnatal life, to identify any trauma, and not only identify, but take action. What do we do if we find a problem? How do we minimize that problem while we either continue or stop the examination and ask for support? To assess the overall well-being of the newborn, to make an action plan for immediate and follow-up care, and to consider what education do we need to do now and balance it with the fact that we're dealing with a woman who's just given birth and is very tired. We need to minimize what important things that we get across and leave the rest for postnatal. And also, it's all very well if the baby comes after our examination to be normal, but how do we share information that deviates from normal before we bring a doctor? We can't just find something wrong and bring a doctor into the room, because the woman hasn't got herself together to know what she's dealing with and what questions she might want to ask the professional. Before we start the examination, it's very important that we have the history. The history needs to be undertaken every time we go near a baby, even if just to find out why the baby is not feeding on the breast. We need to find out the history. And this goes with the first hour examination, specifically the labor and what we're dealing with when we're examining this baby. Vitally, and it's said in NHS England, attain every report that we see, we need to give women the chance to get to know their newborn baby. We need to make sure within that after birth, we examine the baby at 1 minute, 5 minutes, and 10 minutes. After that, once we're dealing with a normal baby, we need to go forward and allow that baby to get to know his mother, and for the mother to get to know her baby. And that means we are in the room with the mother. The new guidance from BAPAM is to minimize postnatal collapse, is that we're in the room, and we're in that room to observe. And I have to say, with any examination, we need to look and listen, because that will give us far more information than any stethoscope can. And what are we looking at? We're looking to see how the baby's on the breast and how well it's sucking. By looking at that, we can actually tell that the baby's neurological system is functioning, because in order to suck, swallow, and breathe, we need to have our brain active, and the 12 cranial nerves are functioning. So I've got huge amount of information just watching that baby feed. We also need to encourage skin to skin, and if the woman is willing and is consent to have that done, and remember in some cultures that may not be something the woman may want to have. So we need to make sure that while the baby is having skin to skin, it is safe skin to skin, that the chin is away from the chest and is kept warm, and we're there to minimize any harm that may come from that. And we're supporting the ongoing care with skin to skin. Now, this is the challenge. The challenge, and I teach that when I'm going in the clinical area. We are so used, and I used to be one of those midwives, that I used to go ahead and examine the baby. And when it came to a sensitive area, like putting my finger in the baby's mouth, I would stop and look at the mother and say, you remember I said about putting my finger, are you still okay with me doing that? And remember when I wanted to do the genitalia, are you still okay with me? That means in taking my eyes away from the baby and looking at the mother or the father, I am taking my eye away a very important time. This is a baby. I have 2 clients in my care now, the mother and the baby. Before I start the examination, I would have explained the complete examination. And going back to what Anna said, informed consent isn't saying to the mother, do you want me to do this or do you not want me to do that? The mother can say yes or no, but that's not informed consent. Informed consent means she needs to know, why do I need to put my finger in that baby's mouth? Why do I need to use the spatula? That gives her the right to have the right information to make the choice. Otherwise, she's making it blind. And if something goes wrong later, she would turn around and say, but Stephanie, you never told me why you wanted to do it. I would have changed my mind and said something different. Because those 10 minutes, 5-10 minutes need to be purely me and this baby. As you can see here, I need to make contact with this baby and observe it every second to give me the information. His behavior is his language, and I need that to make me make informed choices. I also need to know he's been through labor. She or he has been through labor. And labor that's normal is just as problematic. Birth is the worst journey we take in our lives. And it's important to recognize that and to treat this baby gently to reduce the stress and pain that this baby may be going through. Normal labor can be just as uncomfortable for the baby as instrumental labor. Allow the baby to lead the assessment. The baby will give you information as to when he wants you to stop and give him a chance to take himself together before you carry on. So he will show you signs like posseting, sneezing, crying. Crying is simple. To stop and give him time to go back again and complete the assessment. Then the top to toe examination starts, and I'm going to race through this, but please feel free to ask me any questions on any points that I raise, and I will be very happy to answer them at the end. It's important to recognize that I'm looking at the baby from head to toe to see that the baby's tone, skin color, and to look at the baby's mucous membranes to give me that. And I can validate that at the end if I needed to with a saturation. But at this point, just the color from head to toe will give me the... I needed to do the temperature. Now, if I'm doing a home environment, that's more a challenging temperature, but I would have made sure that the environment was warm enough. In the hospital, we're lucky to have the resuscitator. But taking the temperature and getting a reading isn't good enough. I need to know why I'm taking it and how real is it. For example, you see me here taking the temperature of this baby axilla, and the reading could say 36.5, but is it really 36.5? Because I also know from my theory that I've learned is the fact that brown fat is under the axilla. If the baby's temperature was 36, brown fat would be activated and my recording would be 36.5, but really the temperature of the baby is 36. How do I validate that probe? And that's by feeling the baby's extremity with his abdomen. Then we always start looking at the baby, and I always start next to look at the cardiorespiratory system. And this is the framework I use every time I assess the respiratory system. I count the respiratory system for a full minute, and then I look at nasal flaring, and then I look at grunting. If it's inspiratory grunting, that's grunting noise when the baby breathes in. I will not be inserting any spatula because there may be damage of blood vessels at the back of the throat that I may damage. But if it's expiratory grunting, it gives me the idea that the problem is lower airways and I'm dealing with either fluid or infection. Then I'm looking at symmetry of the chest movement. Now, you will not recognize, well, some of you may be very aware of this, but babies take a huge breath when they first come out because they have to move all that fluid out of the lungs and into the lymphatic system and get air into the lungs. In doing so, they can actually cause themselves to have a spontaneous pneumothorax. You don't want the baby to wait 8, 10 hours, 12 hours later when you send this baby to the postnatal one, it can go sleeping next to his mother as the mother's asleep. nobody will realize that this baby's in trouble. This assessment will give you an indication of how the baby is to deal with it now, not 6 hours, 10 hours later. We need to look at the effort of breathing. Now, if I'm standing at the end of the table or resuscitator, I will not see the baby having a problem. But if you look at this slide here, you would see that this baby's got some sternal recession. I would only see it if I go to the side and give it eye level to see that this baby is having difficulties already at 1 hour following birth. Then the cardiac assessment. Well, we're not going to do a complete SEN examination, but we need to know which side is the heart, so I know which side to put the stethoscope on. And then I need to listen and make sure I listen long enough to hear, is it sinus rhythm? What is the rate? Is it a normal rate? Is there any arrhythmias? That I need to take on board. Then I go up again to the morphological system because that's more uncomfortable with the baby because it's been through labor. So I need to take that into consideration and watch what I do with my hands and how firmly I press them against his vault to identify sutures and any trauma that the baby may have. Then I come down to the face. Now, I have to share with you, this week I've been informed by one of my midwives that she examined a baby that was 30 plus hours. And this baby was a Downs, and nobody had recognized that at birth, and the mother didn't have any idea of this happening. This is not the first time it's happened, and it's happened to me as well, that we don't review this baby to see whether his morphology is what we expect. And we do that by looking at the baby overall. Then we look at the baby's eyes. Are they appropriate position between the two of them? Is the two inner canthuses the same as the inner and outer canthus of the baby's eyes? Then we also need to be thinking about, when I'm looking at the eyes, just to ask myself, is this baby got any secretions from the eyes that may be sexually transmitted diseases? And very importantly, has he got any conjunctival hemorrhages? If the baby has them at this time, not a problem at all. But if the baby doesn't have any conjunctival hemorrhages now, but has them on day 5, then I need to be thinking of safeguarding because this baby doesn't have them if he hasn't been born with them. Perfectly normal to have them at birth, a huge problem if they happen later on in the postnatal period. Then I looked at the position of the ears. They're wonderful to give me a lot of information. They give me information on how the baby's ears have formed. Is it the appropriate gestation? A baby at 38 weeks, ultrasound is 2 weeks either way. So this baby could be 36 weeks, not 38 weeks. So I'm dealing with a late preterm. What is this baby, term or preterm? Then I need to think, can this baby have an external meatus so he can actually hear, or does he not have any? Then I'm going down and looking at the philtrum. Is the philtrum the appropriate size, or is it wide? Am I dealing with a baby that mother has utilized alcohol? Then I'm going down to the mouth. Now, I don't examine the mouth now. I leave it to the end of the examination because it's disturbing for the baby, and I want to complete the examination before going into the internal structures. All I look for now is whether the airway is clear and whether I'm dealing with a baby that may have, if he has got a lot of secretions. Did I look at the history properly? Was there polyhydramnios? Am I dealing with a baby with esophageal atresia? That's quite a major problem that I need to take forward. Then I come down to the baby's chin. I know that the chin keeps the airway clear. So if he has got a little one, small receding chin, I'm concerned how to manage this baby and need a second opinion. Then I come down to the baby's neck. Can he rotate it from side to side? Then I continue down to the arms. And then I noticed that the baby throughout the examination would have moved both arms. But then sometimes when the babies, and we hear from this, I'm not sure about you on the call, but how many of you have noticed that babies have been identified now? Maybe we're looking for it and identify it more now than we did before, but they are coming up with fractured clavicles. And the fractured clavicle is extremely painful for the baby. And we need to make sure how to manage it now to complete the examination and how to minimize the pain for the baby and how, with the baby strapped to his arm across his chest, can be breastfed, that we need to provide the continuous support for the mother. Vitally, we're not really the ones who are doing the first examination. I bet all of you know on this call, the first examination is by the mother. The moment you hand her a baby, she's gone through this baby with a fine tooth comb. She knows exactly what's right and what's wrong with her baby. We need to take the time before we start the examination and say to the mother, is there anything you'd like me to focus my attention on? Try not to use the words abnormality. As Anna said, language is very important to enable the mother to be free to tell you what the problem is. If you just say, what part would you like me to focus to look at, rather than say, is there anything that you think is not right for this baby? Then that will make her in a difficult position. She might not share with you what she's worried about. Now, we know that probably we count the fingers anyway, even though the mother has. We make sure there's nails at the end of them, because you'd be surprised how one nail missing, it may not be picked up by a practitioner, and that can indicate syndromes in your baby. But vitally is the grasp. The baby can move, like this baby's moving his arms, but he cannot grasp. It means that it's got a nerve damage. We need to sort that out sooner the better. Then I come down to the abdomen, which is one of my pet ones that I would like to discuss even more, but I haven't got the time. We look at the abdomen that is rounded and there isn't visible peristalsis, but the cord. The cord needs to be left quite long, as you could see here. The longer, the better. And then when it comes to this examination, I can put the baby under the lights and view this cord to see that there is no secretions coming from. But vitally, I know in embryology, the abdominal contents, the intestines, develop outside and then go back into the abdominal cavity. Maybe a bit, the major ones you could actually see, but a tiny bit of intestine in the cord needs to be viewed and excluded before you go ahead and cut through it. Because now I've got the chance and I can leave it long and get for a second opinion, or if it's okay, I will cut it to the right length, because the baby doesn't need to have this length of cord attached to it. The groins reviewed, especially on crying, because if the baby's crying like this, it's a good time to look at them, because you may notice a hernia then. Speaking to experts on consultants on ambiguous genitalia, it's important to recognize we need to not validate the sex until we have actually looked at the baby, and at this point, and then say you've got a male or a female. And to validate the sex of a male, you need to make sure you look at the genitalia for gestation, and also look to see that the baby hasn't got a hypospadias. You'd be surprised how many hypospadias have been missed. We need to really look that the external meatus is where it should be. We are looking at the testes where they're descended, but this is an emergency, and we are aware of one hospital that had 3 in 1 month. Testicular torsion should not wait for the main examination later on. This is a medical emergency and needs to be picked up now. What are their scrotum? Is it equal? Is it discolored? Hydrocele is normal, but the mother would get worried, so we need to explain that to her and what it means. For the female, it's just as important to review the male genitalia to validate sex. We need to make sure that we can actually separate the labia majora from the labia minora. Just looking externally does not give you an indication. Then we need to make sure that we see that the hymen is patent. Now, you may say, why are you worried about that? Well, it's not a problem to a baby now, but when she starts to menstruate later on, she can't. And there will be huge problems, which I haven't got time to go into now. But we need to validate, because the hymen is quite low at this time and is visible to us to be able to view. So if there's no secretions, we need to visualize that it is patent. This is important, the perineum size at this hour exam. If the perineum is short, it is vital that we pick this up now, because this baby will have to go as a medical emergency, because the earlier the treatment starts, the better the management in the long term to avoid later on uterine infections. The spine, most of you on this call would be like me. I was taught to just hold the baby up, run my finger down and check the spine. Now I know this is I will have to lift the baby up to see that the baby's spine is straight, but immediately I put the baby down, because this is not only uncomfortable, but dangerous position to examine the spine. And in examining the spine, I need to make sure it's intact, there's no dimples, and if they are, how far away from the anus is. This is the important part, the anal wink. I can't tell you, in the past, I was taught, and maybe some of you are at the same time as me, to put thermometers in the baby's rectum to look at the temperature. Now, you'd be aghast at this, but this is what we did years ago. We're no longer doing that, but we need to make sure that the anus is patent, and that's really looking at it while it's prone properly and make sure that there is an anal wink. This is the time to look at the buttocks for any fat that isn't present. So you expect the baby to have adipose tissue. That's what maintains his glucose. So a baby that's small for dates and it comes less than the 2.5, I have a number to work with, great. A baby that's light for dates can be 3 kilos, but I need to look at the baby closely to see how much adipose tissue it has, and I need to compare it with the head circumference, and a 2 centile difference would alert me to the fact that I've got a baby that I need to manage with the senior neonatologist to prevent hypoglycemia and other issues. This is the other one. We concentrate on breastfeeding, but we need to concentrate just as much, if not more problems can occur with artificial feeding, especially at this first feed. No baby can be given an artificial feed until we examine the internal structures of the mouth. We first do a digital examination, and the advice is to put a spatula in and view to make sure we haven't missed the cleft palate. Now, in this picture, you see a spatula going in and for us to view. Now, this spatula is held in this position in order for us to see the cleft, but in actual fact, our finger should be at the end of the spatula. What has happened recently, and I've heard there might be new guidelines coming out, the baby's tongue, for those of you who have done this, is very strong and can lift it up and split the spatula and cause splinters to go off into the baby. So it's important to put it in a glove, in a finger in a glove before we examine. The other thing before we actually talk to the full examination, we need to make sure that the baby hasn't got respiratory distress. A baby that is trying to breathe rapidly and also swallow, it's not going to do it. I can't do it, nor can the baby. So has it got any, exclude that. And then make sure we're there to give the first feed. We're there for the first breastfeed. We must be there for the first artificial feed, because I can tell signs for atresia, but tracheoesophageal fistula, I can only manage it to see it when I'm giving the 15 mils at the first feed with this baby. So be there when that first feed. And in conclusion, when I finish the examination, I then shut away all the noise, all the people around me, and then go through mentally the top to toe assessment. Have I done everything? Have I forgotten something? If I have, not the end of the world. Do I go back and do it now, or do I do it later? It's nothing worse than dressing the baby and then recognizing you haven't done something. What actually is my action plan? And if I found a deviation, do I need a second opinion, and from whom? How do I share the information with the woman? And this is important. The language we use and how we share this is vital. It's important to give the correct weight, the information to the woman, so you don't terrify her, but you balance the information. And she knows that a doctor's coming in for a second opinion to help us continually support the baby. And for her to know lots of conditions can be treated beautifully today without any problem. But what I also recognize, bombarding her with education is not the right time. The birth time is the last time. It's the least time you're going to be given. You just give her the minimal amount of information, because she is trying to accomplish and stay compos mentis after a long labor. Even a short labor is enough trauma for that woman. And as you can see, Winnicott, who's a major psychologist, has actually done research that the women has said we are dominant, we are not very nice, we are precursory. We need to take that into consideration when we are sharing information and how we are dealing with the woman. Ask about how she is before we start talking to the baby. Thank you for listening, and I've managed to do, I've gone over the time again, sorry. Please put your questions and comments on the chat. Thanks very much.
Thank you, Stephanie, and thank you, Anna. I think you've given us, I think, a huge amount to think about, because I think it's challenges an awful lot in the word. I think Anna's talking about the words does challenge you to think these words we use, we don't necessarily think about, do we? That, you know, birth outside guidance and sort of almost labeling a mum or a woman or a birthing person in a particular way. And you kind of think, when you said, well, it's personalized care, I'm thinking, phew, thank goodness for that. Because for me, I think, and anyone here that's had to require any, well, if you go to the dentist, you go to the doctor, anything, or the midwife as a pregnant woman, you don't want to be labeled, do you? And you want to have your choice and your person respected. So that's really a good thing to be thinking about in your brain. I'm talking now because I know your people are just putting in questions. There's always a little bit of a delay. The other thing I was thinking as Stephanie was talking, I was thinking it's very interesting because I mean I'm imagining this examination is always done, because it's certainly, as a student midwife many years ago, this was a really important part of our students, the completion of our supervision of care. And it was a really lovely bit of the birth. But of course, we did a lot of other things when we did that examination, because I remember doing the hips, which we don't do now, and you know, lots more checks. So in a way, it's a much more targeted assessment, because obviously hips are done a little bit later and you have to be quite experienced at doing that. But is it an issue that babies aren't being examined? Because something you said, Stephanie, made me think, is it always done? Are people waiting maybe for the proper examination?
That's why I was glad that you asked me, Sue, because my students' feedback and my personal feedback when in a clinical area and as midwives, we are now delegating a lot of that examination to the 72-hour assessment. And that's dangerous because we are hearing of neonatal deaths in the postnatal ward because that examination has not been undertaken. So it's important to recognize they're two very different examinations. And we cannot delegate this examination to the 72 hours or 12 hours. Even 6 hours is too long for a baby that has a problem to wait. And if you have founder syndrome, the quicker you get help, the better the long-term outcome. And that's what we're there for, to provide best care to reduce the morbidity, not just life for this baby and his family, really.
Yeah, because I mean, I think your discussion of the mother examining the baby, I mean, that the mother will often know that there's something that's not quite right and will ask. And you're giving her a sort of window to do that. I mean, it's interesting, isn't it? Because that then makes me think what Anna was saying about her students not necessarily getting the experience that they need to finish, because of course, and those of you watching who are students will know, especially in the UK, you have the clinical record experience, the MORA, to complete, and it becomes very important. You've got to get all those numbers in, and the numbers, I mean, some people criticize the numbers, but you kind of need those numbers to get that experience. And it strikes me, if the student isn't doing the, I mean, it's okay. Well, I'm assuming that it's okay for students to do these examinations still, Stephanie.
Well, thank you
Under
for pointing.
supervision, because they're always going to be
Yeah,
under supervision, aren't they?
absolutely, absolutely. It's vital. And what I say to my students, you cannot start the 20 examinations until you've done the majority of the 40 examinations and the majority of the 100 postnatals. Unless you've done that, you're working blind when you come to the 20 systematic examinations. So I keep an eye on my students and what they're doing each year, how many antenatals, how many birth ones, and how many postnatals they do before I say to them and the CPFs to go ahead and start the systematic, because it becomes a task-oriented exam rather than evidence-based exam for that baby. So it's very important that we put the context, as you rightly say, on the 40 and 100 and not just the 20 at the end of the exam. It's the culmination of the 140 that the 20 brings. So thank you for bringing that up, Sue.
Because I mean, it just makes me think, in a way, we just took it for granted we did all that, and we were doing the right thing, and picked up a lot. And you do pick up a lot. Anna, going back to this now, how can we address this language?
Yeah, it's a great question. I think what we need to do first of all is for clinicians to start to feel comfortable with those choices in the first place. But and I've seen it already with people that I've worked with and shared my work with, that they're already just using the language and it just filters out. I think there is some kind of system level work to be done around, what good clinics look like. Consultant midwives are brilliant, and I work with lots of brilliant and still talk to a lot of consultant midwives, and actually they're the ones leading that. So leading from the top and feeling comfortable to be able to kind of own that and own the change in language and realize that it takes one person to start that. Yeah.
Yeah, I was thinking, I mean, again, because it's good that you talk about consultant midwives, because of course they do.
Yeah.
But then it makes me think, and we're all teachers,
Yeah.
when students come back and say, but when I said this, the midwife said, oh, that's what you do in school. That's not what you do in real life.
It's one of my bugbears, and I have lots of them, as anyone knows. I've got hills that I'll die on. And one of them is that kind of gap, isn't it, between when students come to us and they'll say things like, in the real world, this is what we're really seeing. And I make no apologies for sort of saying to them, actually, I'm teaching you gold standard care. I will always go back to the law, the regulatory kind of framework, and also, the moralistic framework around consent and personalized care, because if it becomes second nature, then when they are the teachers of the future, the reason advocacy is not necessarily being seen out in practice is because that, you know, the people that are doing that now didn't see it when they were students. So it takes someone brave to stand up and say, actually, you know, I'm just going to make this minor change. And this is the other thing. It's a very, very small change, that will build up to bigger things.
Mm. But it's quite it is a brave.
It is
I
brave.
agree with you, and quite tricky
Mm.
to kind of institute on your own.
Yeah.
And I think it's very interesting because this is so much about changing practice. What you're
Yes.
both talking about, there's so many threads between what you've been talking about, which really makes it come alive, because it's letting go, and especially for in a way, it's recapturing what we used to have in the olden days,
Yeah.
us old midwives, and realize the importance. Because I think at the time we didn't have now, Stephanie used the SEN word, the systematic examination, the newborn
Yes.
words. We didn't have that
Mm.
when some of us, and I'm talking to some of you midwives out there who same vintage, who didn't do that examination because that's comparatively new practice. And we're still now introducing it much more to student midwives, so it's going to become very mainstream. But it's kind of realizing now that some of the things we just took for granted as student midwives and midwives years ago, we were looking for and we picked up. That was a good thing to do, but we have a lot more tools now. When Anna was talking about the tools, and we've got so many good tools, and some of them are on your wee list, but some of you catch along the way, because of course the NMC code is a very strong tool, and the proficiencies, the NMC proficiencies. And I have to say at this point, with a sort of NMC ear, that those proficiencies are not just for students, and they guide the curriculum for students, but they're also for us as midwives. And those of you who've done, if you've done your revalidation recently, you'll know you have to incorporate all that in your revalidation. There we're all going, oh yes. And okay, we've got now Diane Garland. Hello, Diane. Now Diane's off to Crete next week to a Greek
Oh no, I'm so
festival. You
envious.
see?
Me too. Really jealous.
So
I'll come
hi,
and carry your
Diane.
bags, Diane. That's fine.
You've got offers of taking bags, but she says welcome back and thank you for the session. So that's well done. I think you might have stunned the audience. Now, if you think of any questions that you haven't been able to formulate, just get in touch and we can pass them on to Anna and Stephanie. And I know they'll both be very happy to respond to you. And I know it's a lot of information to take in. And like I always say, this is the fastest hour in the whole week. So I want to say huge thank you to Stephanie and Anna for joining us. I'm going to thank also Angelo, who's in the background. Now he's making sure everything's recorded beautifully so you can recapture this and play it again. And like I said earlier, play it and share with your colleagues, because it's a really useful thing to do, to just set it in your brain. And also Paul, thank you to Paul for sending out the questions through to me, or the comments through to me. Now, this is going to be available. This is going to come out again with a link on Tuesday, and it's also for those of you who are early birds, will be available at 6 o'clock in the morning on Friday. Okay, that's good. Now, next week, we're looking at sharing the news that the baby has Down syndrome, and that links back to Stephanie and supporting families. And we've got Varshali Swadi, Professional Engagement and Development Lead, being joined, which has a parent of a child with Down. So that's will be really useful for those of you we all need to know how to deal with supporting families who have to deal with a baby with additional needs. In the meantime, the Cardiff Festival's next Tuesday, and I'm going to say, I'm sure some of you will be there live, face to face, and some of you will be coming in online. So I'll look forward to seeing many of you there. So come and say hello if you're there. It always makes me realise, actually, I love the Maternity and Midwifery Hour. And I think we have some really good discussions. And every single week, I learn something new, which gets in my brain, which is fantastic. And I hope you all do too. But also, it makes me realize that when we go to the face-to-face events, they're fantastic too, because we as midwives really work well talking to each other and networking. Now, Anna's going to be doing that at the weekend with all her group of midwives, and I can just imagine the delight. That's going to be absolutely fantastic. And that are you sure is it a lunch? Is it more than
It's
a lunch? Is it a
well, it'll
day?
start as a lunch. No, it is a lunch. Because we've all come around. I've got a colleague coming in from Dublin. She's flying in that morning, then flying back again. So
Oh
yes, it'll be a
wow.
lunch.
Gosh, fantastic.
Yeah.
I think there should be champagne on the menu.
Okay, I'll tell them
Fizzy
you said
pop.
that. I said Sue said so, so we're going to do that.
Fizzy pop or something.
Exactly.
Anyway, so have a wonderful time.
Thank you.
Thank you so much again, Anna and Stephanie. And
Thank
we'll
you.
see you same time, same place next week. So take care.